Our greetings and welcome everybody to our last CPC session for the year. We're just going to give it a few minutes to allow everybody join in, and we shall be starting at exactly 5 minutes past 7. Feel free to tell a friend to join in, tell them that the CPC sessions have started and they shouldn't miss out. Great. I think we can now get the ball running. Good evening, everybody, and welcome to this evening's CPC case, emergency medicine case-based series discussion, whereby today we are going to be talking about the deteriorating pediatric patient who came in with a complaint of my chest hurts. My name is Okume Emmanuel David. I will be your co-host for today's session, and I'm privileged to be introducing to you our expert lineup that we have had for you today. We have lined up for you a brilliant group of individuals who are going to take us through today's discussion. Our expert for today is going to be Dr. Andrew Chimera, a pediatrician and child health specialist. Our presenter today is going to be Adrian Chiveru. He's a fifth-year medical student at Makerere University. And we shall also have Charity Kayesu, a year 2.1 pre-hospital or paramedic student at St. Michael Luwaga Hospital. You're all most welcome for our last CPC session of the year. And without wasting any more time, we shall dive into our case discussion today. So we have our presenting complaint that is going to be brought out. I will request Charity to kick us off with the presenting complaint. All right, since Charity is not yet in the call, Adrian, could you take us through? the presenting complaint.
Good evening, everyone. All protocol observed. I would like to once again welcome you to today's clinical pathology case presentation. My name is Adrian Chiweru. So straight away, let's dive into today's presenting complaint. Today I'll be presenting a 14-year-old male who presented at Mulago National Referral Hospital at the acute care unit with 3 complaints consisting of fever for 4 days, vomiting for 3 days, and chest pain for 2 days. So at this point, I would like to call on my colleague, Charity Kayesu, to take us through the pre-hospital management. Thank you.
Yes, thank you, Adrian. So we have seen the presenting complaint. So at this point here, we are expecting this patient to be picked up by our pre-hospital team. This team is going to be led by Charity. So Charity, the floor is all yours.
So good evening, everyone. Hope you can hear me. Can I know
Yes,
if you can hear me?
hear.
Okay, thank you. So I'm Charity Kayesu, an EMT, pre-hospital care presenter. So I'm going to talk about the pre-hospital management. So as we are having a 14-year-old male patient having vomiting, chest pain, and chest pain. So these are the requirements that I'm going to be needing as a pre-hospital care provider. So before approaching my patient, I'm going to be needing oxygen delivery devices, which are nasal plugs and non-rebreather mask. So I'll be needing IV cannulas, which are 16 gauge, two or more. I'll be needing IV paracetamol, a space blanket, ambulance type C, which is advanced life support. So the number of staff that I'll be needing, there will be 2 EMTs and 1 driver for more monitoring and interventions. So on the Eastbury port, this is done when I arrive at the hospital facility. So I identify myself as Charity Kayesu, an EMT, handing over a 14-year-old male patient, ensuring clear accountability and continuous care. The patient presented with fever, vomiting, and chest pain, which raised concern for a systemic illness with possible cardiac involvement. So the fever had been present for 4 days, vomiting 3 days back, chest pain 3 days back, indicating a progressive condition. So on assessment at the scene, our airway was patent, therefore with no obstruction noted. Therefore, no immediate airway intervention was required. The respiratory rate was 32 beats per minute. And our SpO2 was 88% on room air. So these findings indicated respiratory distress and hypoxia. So oxygen was delivered via nasal plugs to improve oxygen delivery of our patient. So our patient also had a weak 3D pulse at 130 beats per minute. The blood pressure was 107 out of 72 millimeters of mercury. The capillary fill time was greater than 3 seconds and with cold extremities. So, all suggestive of poor peripheral perfusion and early shock in our patient. So what we did, two large bore IV line 16 gauge were established in both hands. Paracetamol was administered for pain and fever control. Ringer's lactate, 500 milliliters, was given to control dehydration, especially due to the ongoing vomiting that we are having. The patient was covered with a warm blanket to manage the cold peripheral and to prevent the hypothermia. So the following were recommended at the hospital arrival. So the recommendation were the ECG to assess for the cardiac abnormality causing the chest pain that we are having and the tachycardia in our patient. Another thing is the X-ray to rule out the respiratory or the cardiac pathology in our patient. We have malaria RDT due to the fever in our patient, the pediatric patient. Another recommendation is the LFTs to assess for the systemic involvement in our patient. So the last one, we are having the review by the cardiologist due to the chest pain and the signs of possible cardiac compromises. Thank you so much. This is our pre-hospital presenter, Charity Kayesu. Thank you for listening.
Thank you
very
Charity.
much, Charity.
At this point here, we'll allow our case presenter, Adrian, to come back.
Thank you very much, Charity. So we went ahead and performed a primary survey, and beginning with the airway, as earlier mentioned, this was patent and there was no risk of obstruction, and there were no visible obstructions at the time, which was good for us. Next was breathing. The child was tachypneic with a respiratory rate of 32 breaths per minute and an SpO2 of 88% on room air, which indicated that we had a tachypnea and a hypoxia, showing that there is respiratory distress. Third came circulation. He had cold peripheries with a weak and 3D pulse and a rate of 125 beats per minute. Capillary fill time was greater than 3 seconds, and the blood pressure was 107 over 72 millimeters of mercury, which showed that we had poor peripheral perfusion. And fourth came disability, where we assessed the Glasgow Coma scale. It was 15 on 15. People were equal and reactive to light, and the RBS was 4.6 millimoles per liter, and there were any visible abnormal movements, signifying that the child was neurologically stable. Fifth came the exposure. He had an axillary temperature of 37.8 degrees Celsius, which showed us that he had a fever. He had mild conjunctival and lingual pallor, but he had no jaundice, and he also had bilateral grade 2 pitting edema. So at this stage, we shall have a poll, and this reads that from the history and primary survey, what are the imminent emergencies that you can note? Please, we shall request the audience to take part in this poll, and then shortly after, we shall go ahead with the presentation. Thank you.
Yes, the polls have been shared. Just ensure that we all take time and let us fill in the poll question that has been showcased. This is to ensure that we understand from the pre-hospital bit that we have got in the primary survey. Are you able to pick out the imminent emergencies in this case? Please share with us what you think by answering our poll question. The question again reads, from the history and primary survey, what are the imminent emergencies in this case? Are you going with option A, option B, option C, option D? We are going to give some few seconds for this to be completed. Feel free to also put your answers in the chat if you may. For these poll questions are going to be repeated at the end of the session to ensure that at least we have had active knowledge gain in this case. We are going to close off the poll in the next 30 seconds. Yes, keep the questions coming, keep the answering going on, and we shall be closing our poll in 3, 2, 1.
Okay, so at this point, we wanted to take time and try to identify the emergency conditions that this patient presented with. Remember, as earlier mentioned, the airway, we really did not have any issues. So we wanted to assess, as per the breathing and circulation, what threats do we have available? And particularly starting with the breathing, we asked ourselves priority questions. Number one was, is this patient breathing? What is the respiratory rate? And what are the O2 stats of the patient? Our findings were that the patient had a tachypnea of 32 breaths per minute, and he had a hypoxia with an SpO2 of 88%. So the risks associated with these findings included hypoxic respiratory failure, possible organ damage, cardiac arrest, acid-base imbalance, and respiratory muscle fatigue. And the immediate action that was done was that we gave 5 liters of oxygen via nasal prongs, which saw the saturation move up to 97%. And then the respiratory rate also went down to 25 breaths per minute, which was still high, but better than 32. So, and this was observed after a period of 10 minutes. Then for the circulation, we wanted to ask ourselves, is this patient in shock? What is the pulse rate? And what are the other parameters with the pulse? So our findings were that this child had a tachycardia, he had cold peripheries, he had a weak 3D pulse, and bilateral grade 2 pitting edema. Now, this is not particularly an emergency condition, but when you get this bilateral grade 2 pitting edema and you tie it up with the other findings in the circulation, it can point you in a particular direction. So the associated risks with these findings included, number one, cardiogenic shock, sudden cardiac death, and then a fluid overload. So the actions that were done was that we obtained IV access. We gave IV furosemide, 36 milligrams 6 hourly, started the child on a heart failure regimen consisting of tabs captopril, 12.5 milligrams once daily, tabs spironolactone, 25 milligrams once daily. And then we also took off samples for investigations, which included CBC, LFTs, RFTs, and then a blood culture. And then we also thought that since we are in an endemic area for malaria, we should also do an MRDT. There are other interventions that were not included here that were also done. We considered 10% dextrose, but remember we had an RBS result of 4.6 millimoles per liter, so we didn't think this was required at this stage. And the others were that the child was given IV ondansetron 8 milligrams thrice daily, and IV ceftriaxone 1 gram OD as empirical treatment against a possible infectious process going on since we had a fever, and then IV gentamicin 100 milligrams once daily to cover the gram-negative organisms, also as empirical treatment. So at this point, I would like to invite our expert, Dr. Andrew Chimera, to give us his initial remarks. Thank you.
Thank you, the presenters and everybody hearing. Glad to be here. So this is a 14-year-old, so every piece of information for a child is important, as the team has tried to elaborate herein. So a 14-year-old that came, the presentation was fever, vomiting, and chest pain later on. You see a progression of symptoms. So initially you're thinking this is chest pain that could emanate from two different places. Could it be the lungs? Could it be the heart once we think of the chest? But the point of having a fever already suggests an infectious process or an inflammatory process that could be associated with this pain. Then we come down to the different thoughts here. You're already thinking, could it be something to do with the lungs? Could it be something to do with the heart? Then we go on further to look at what the responders found in the field as they were assessing this patient. They found that they were tachypnic, which we can always see with a child who's running a fever. They found that they had compromise in their oxygenation. They were hypoxic. That father still tries to tell us, yes, it could be the lungs as well. It could still be the heart as well, because one can also affect the other. Then we get into the circulation where we had a weak 3D pulse, okay? And that was raised, the BP was on the lower end. Then features that were suggestive of circulatory compromise, and features that are suggestive of circulatory compromise also further bring in the idea that one, yes, this could be, yes, still an infection from the lungs, but causing other constitutional symptoms like the nausea, the vomiting, and the rest. Okay, so not yet fully taking it out and knocking it out. And then the peripheries that are getting clammy and cold, still trying to tell us that we are getting in shock. Is this shock from hypovolemia loss? We are not taking in much. Are we losing a lot while not taking in much? Could it be primarily from the heart? Because remember, we have chest pain. The central organ is the heart. So you're trying to delineate what sort of shock it is so that you don't make a mistake in how we manage this child. Then further, we look at the child having edema. So pitting edema, they mentioned the child was not pale or anything, didn't have jaundice. So some of those things further try to narrow things down for you, as we later shall see as we get into the examination of this patient, maybe in the secondary, and get more history. Some of these things try to further tell you, if it's jaundice, could I still be having something infective Could it be an infective endocarditis? Could it be a child who's having rheumatic fever with pre-existing heart failure? Could it be actual myocarditis from a viral cause that can acutely compromise function of the heart? Could it still be a pericarditis from another infectious cause, mostly those viral causes? So all those things are still possibilities, but the presence of the edema now starts to narrow us down and make us think, could this be more of something to do with compromise to the heart function? And we are not perfusing very well because we are having issues with how the heart muscle is pumping. So it's something infectious, but more likely to do with the heart. So we have to exhibit caution with the fluids. Okay, I like how the team in here also said yes, we could give some fluids, but they were still doing a little bit of Lasix, just being cautious not to overload this child. Of course, definitely thinking of overload might not be a thing because the child is actually vomiting, they're not taking in anything, and you're picking them. Then also, I noticed a bit of some of our pre-workup electrolytes. Remember the renal functions and electrolytes. Remember, we are thinking organ dysfunction as a possibility. Every time you're in shock, there's likely to be compromise of certain organs. So the renal functions are key in there. I noticed maybe we hadn't had them in there, but also the electrolytes. Because remember, even arrhythmias and things like that are things you're still thinking about, but you're more narrowing yourself and biasing yourself because of what we have found to more of a cardiac related issue, thinking, could this be a myocarditis? Could it be coming from arrhythmias from the heart? Are we in failure from an acute carditis? Could it still be rheumatic fever and you're having a secondary event or infection with a pre-existing already existing damaged heart with valves? Now we are in failure. So all these are thoughts, and it still further narrowed that down to infective processes within the cardiac. Yeah. So those would be my thoughts at the moment. But still, we carry on the possibility of chest infections because you can still have both. You could have one exacerbating the other. Okay? Yeah.
Thank you so much, Dr. Andrew. We are going to proceed with our presentation. That was such an insightful debrief into what we have discussed so far. Let me invite Adrian to take us through.
So at this point, we took a sample history and we started with the signs and symptoms to kind of get a better understanding of this patient's presentation. And he had central chest pain for 2 days, which was stabbing in nature, not associated with respiratory movements or change in posture. And it was associated with palpitations, easy fatigability, lower limb swelling, but there was no cough or difficulty in breathing. He also had fevers for 4 days with reduced appetite, postprandial non-bilious, non-bloody vomiting for 3 days with an average of about 3 episodes per day, and weight loss, but there were no loose motions. There was no history of headaches or vision changes, no joint pains, no prior throat infection, no night sweats, no reported, I reported normal micturition habits with pale yellow, non-frothy urine. For the allergies, he had no known allergies to food or any drugs. For the medication, he was not on any medication at the time of admission. For the past medical history, this was his third admission. The first was about 5 years ago, which was due to acute watery diarrhea, which was unrelated to this particular presentation. And then the second one was where he had 2 blood transfusions because he had severe anemia. And then this particular one was the third. His last meal was a meal of porridge, which was about 8 hours prior to admission. And some of the events leading to the presentation were that he had been unwell with fevers and body weakness for about 4 days. Later developed vomiting, reduced appetite, and then the chest pain earlier described. So at this point, I would like to again welcome our expert, Dr. Andrew Chimera, to give us his thoughts about this history. Thank you very much.
Okay. Thank you very much. Very interesting there. So I like that we tried to really try and explore the cardiac causes. For example, I can see from the history, we said this is retrosternal chest pain radiating to the back, not worsened or exacerbated by change in posture. Okay. There were a few more things that would have been very important. Does it worsen when we breathe, take deep breaths or not, you know? And did we experience symptoms of fatigue, night coughing, paroxysmal nocturnal dyspnea, and the rest? But peculiar here is the 2 transfusions that we'd had the previous week. Okay, in such a child, a 14-year-old. I'm just asking myself, could this child actually have another hematological disorder, for example? Could they be a child with sickle cell disease still, and they are having still a chest infection? Okay. Could they be a child who's even after the transfusion, they are still having sickle cell related cardiac disease or cardiomyopathy, which can also lead to arrhythmias? I'm still asking myself, could it still be rheumatic fever with an already underlying compromised heart? And could it still be myocarditis, okay, in this child? But the blood transfusions from the medical history is something we cannot completely ignore. So it suggests possibility, if we have transfused the child twice in the recent past, could they have also, you have to think of other things in there. Could it also be an as we introduce blood cells, we increase the viscosity blood, and could we also be having a pulmonary embolism? Okay, very important, and it can also cause such symptoms that retrosternal chest pain, that dyspnea, the vomiting, and the rest. So two things there for me as I'm thinking through this patient. I still know there's something wrong with my heart, but also it could still be, like I said, don't forget about the respiratory system, because one can offset the other. So from such a history, following the transfusions and all, could we be in a hypercoagulability situation where we could actually form a pulmonary embolism that can actually compromise oxygenation and lead to a number of these symptoms, and one system could acutely affect the other, especially if we already had an underlying condition. Yeah. So the things I would want to know, does have they ever done a sickle cells test, and also are they on any medication chronically? Okay. And additionally, It would be good to know how many times they've had these hospitalizations where they require transfusions in their past history, their family history of sickle cell disease, or even heart disease, or sudden death from the family. Those are certain things that try to narrow you down to think through. Could it be something we already have a pre-existing heart condition? Because you have that chest pain, you have hypoxia, you have a child who's showing circulatory compromise, and they've had transfusions before. So you've introduced blood cells. Was it a child who had sickle cells? Could we have gone over and transfused beyond usually we would like to have them between 10, no more than 12. Otherwise, you cause hyperviscosity, which can cause a few other issues in this child. So for me, could we have family history of sickle cell, any chronic medication, and history of sudden death in the family? Would be some of the things that I would be interested in knowing for this child. And also, in the past 2 weeks, previously, did they have any sore throats? And yeah, and then also before this event, were they otherwise fine? Was this a sudden event that they started with getting a fever, then they had vomiting, then they are hypoxic, feeling uneasy? Yeah, so the timing is very, very important as well. Because still the 4 days suggests it's acute, but before the 4 days, what was the situation? Were we well? Was there anything? Yeah, thank you. Those are my thoughts at this time. Hello?
Yes, thank you, Dr. Chimera, for that insightful thought process there. We're just reaching out to Adrian. Back to you. Could you help us answer some of the questions that Dr. Andrew has tried to poise out today?
Okay, I hope that I addressed all of them. The first one that I want to talk about was that you talked about whether you wanted to know whether there was a history of prior throat infection. That was explored, and the child did not have any prior history of throat infections. I asked about a history of sickle cell in the family, but and also having been tested for sickle cell, and the child had never been tested for sickle cell, but this was something that they had never heard of in their family. I also explored around the siblings to see whether any of them had ever gotten a similar condition, maybe episodes of chest pain or joint pains or anything like that. But it was not the case for this particular patient. Then the other thing that I wanted to address was about the state of the patient leading up to this particular presentation. This is a child who had been sickly, I would say for the past 1 month. They were feeling weak. They were the symptoms that I presented within the sample history. There were some of the symptoms that I elaborated on were the same symptoms that the child was feeling over the past 1 month. Of course, when you're asking about this history, the patient tends to compound some of the symptoms that they have been feeling over time. But these were the symptoms that they have been feeling. They have been feeling symptoms of palpitations, fatiguing, body weakness, and stuff like that. So really, this, as you said, was pointing towards a possible cardiac issue. For the history, for about the blood transfusions, the child had.
Sorry to cut you short. We are spending most of our time, and our time is being fast spent. Could we just rush on to this? The rest of the other questions can be answered in the chat. Sorry to cut you short.
Okay, thank you very much.
At this point, would want any additional information that the audience would want to ask. Feel free to join the conversation in the chat. If you have any additional questions you would want to ask, feel free to raise your hand up. We are going to give about 30 seconds for whoever feels like they have a question that they would want to be answered. You can use the chat box, or you could raise up your hand. Remember, this is an interactive session, and we're trying to ensure that we all live here with information that has been learned. So don't be shy. If you have a question, you can still raise up your hand. We shall pick you, give you then a chance to ask your question. Other than that, you can still use the chat box to ask your questions. We shall be closing off this session in the next 10 seconds. Yes, we have a question in the chat. This is coming from Mary Teddy. She's asking, what was the HIV status of this child? And then Dr. Andrews keeps on asking, were there any cardiac markers? Adrian, could you answer this in like 10 seconds?
The child was HIV seronegative. This is supposed to have come in a different segment of the presentation, but just to answer the question, the child was HIV seronegative. And at this point, we really did not have any cardiac markers available.
All right. And then we can proceed with the presentation.
Okay, so moving on with the secondary survey, starting with the head and neck. The child had a soft neck. He had mild conjunctiva and lingual pallor. There was no jaundice. There were no distended neck pains, and the JVP was normal. As per the chest, he had intercostal recessions. The trachea was central. There was a resonant percussion note in all regions. There was equal bilateral air entry in all regions, but with fine basal expiratory crackles bilaterally. He had a hyperactive precordium with a displaced apex beat in the 6th intercostal space anterior axillary line with apical heaving and anapical thrill. S1 and S2 were hard, but in addition to those, we had a grade 4 apical pansystolic murmur radiating to the axilla and loud down tilt in the patient on the left side. As per the abdomen, the child had a scaphoid abdomen with normal respiratory movement. He had a tender right upper quadrant and hepatomegaly of 4 centimeters below the costal margin, mid-clavicular line, and no other palpable organomegalies. As per the skin, there were no visible skin bruises or nodules. There were no stigmata of effective endocarditis. So at this point, we would like to have our poll, a second question, and it reads, the following are a possible differential diagnosis for this patient, except, and among the options, we have acute heart failure exacerbation, severe malaria, meningoencephalitis, and severe pneumonia. Please feel free to participate and give us your thoughts. Thank you very much.
Yes, we are going to have rush to this bit of the session. Feel free to share your thoughts with us as we take on some of your answers for the poll question that has been shared, and keep the questions coming in, the interactions in the chat question and the chat box, where we have Dr. Ann, who is going to be helping us answer some of the questions that you may have and may not be answered necessarily during the course of the presentation. We are going to close off this session in the next 5 seconds. Yes, so would like to bring back our expert, Dr. Andrew, to give us, from your point of view, what are your differentials at this point, and what is your management at this point?
Okay, thank you so much. It's still, like you said, it still brings more light. One of the things that we are sure of, remember, as we started from heart lung. Okay, then we kept narrowing down by the signs, and now the clinical symptoms. The child who has been having on and off fatigue, unwell, and now they are presented to you with an acute episode of fever, tiredness, they are vomiting, they are nauseous, they are basically toxic. You've examined and you're having all the features that suggest that we are having heart failure, and you're having an enlarged heart. Okay, so you're still thinking this could likely be a 14-year-old, average age around 12. There, we are still thinking possibly could it still be rheumatic heart disease with a possible infective endocarditis? Could it just be another episode of rheumatic fever and it has exacerbated uh, the heart condition and caused them to go in failure? Could they still be having arrhythmias from this dilated heart that could also still cause the chest pain and the discomfort? Could they still have a pneumonia? Because if they're having an enlarged heart, they've had recurrent symptoms of being unwell, congestion, they predispose us to pneumonias. So it could still be all those are still in there. Even the malaria is still part of those differentials, because common things occur commonly. You could have malaria that is actually causing the exacerbation in the heart condition that was previously undiagnosed. So for me, it is top on the list. I would still say possibly rheumatic heart disease in congestive heart failure with possible infective endocarditis. I like the fact that we already took cultures. Then we shall possibly have the echo and the rest, then the arrhythmias with the EKGs to be done. Then we also go ahead to do some of the cardiac markers, the BNP, and the rest. Then you have those other differentials. Don't leave out the malaria. Yes, we could still have malaria. Why are we chronically anemic? Don't also forget that it could still be a child who was undiagnosed with sickle cell disease and they had dilated cardiomyopathy. Now maybe they have a vegetation and they have infective endocarditis. So you still have to leave your thoughts broad. Pneumonia cannot be taken away. The malaria, the same. Yeah, those are the thoughts at this moment. Oh, and the management plan? Oh, okay.
All right, thank you, Dr. Chimera. Let's have Adrian coming back.
Okay, so at this point we thought of differentials. Our number one diagnosis that we were thinking was that we could be having a 14-year-old male with an acute heart failure exacerbation, which could be secondary to. We thought of the possible causes, which included, number one, acute rheumatic fever with features of rheumatic heart disease. And the reasons for this were that this was a 14-year-old male, and he was within the age range that usually are susceptible to rheumatic fever, which is 5 to 15. He had chest pain, which is one of the features of the major criteria. He had fever, which is also one of the features of the minor criteria. And he had features of mitral regurgitation as delineated in the examination findings. And then against this diagnosis was that we had no history of prior throat infection, and our Jones criteria was not satisfied for the diagnosis of acute rheumatic fever, but nevertheless, we wanted to put it high up on our list of differentials. The next cause was what we thought we could be having maybe a possible dilated cardiomyopathy, and the reasons for were that we were having a hyperactive precordium with a displaced apex, and features of mitral regurgitation, all of which were examination findings, really. The reasons against this were that there was no history of cancer treatment. Cancer drugs like maybe doxorubicin or cyclosporins can give us dilated cardiomyopathy, but we didn't have these. And then we didn't have any neurological features that were suggestive of vitamin B1 deficiency. So we thought this was unlikely. But again, a third of the time, dilated cardiomyopathy can happen without a particular cause. So we wanted to also put it there among our differentials. And then the other cause we thought of was maybe possibly chronic anemia, given that we had a prior history of blood transfusion. But again, the nature of the heart failure was not typical of high output heart failure. Then among the other differentials, number one was severe malaria. And the reasons for this was that we had fever, body weakness, and pulmonary edema. There's no particular reason against this. Secondly, we had pneumonia because we had a tachypnea, we had a hypoxia and fevers, but we did not have cough. And usually, pneumonia is usually present with cough. The other differential we thought of was tuberculosis because we had fevers, we had weight loss and chest pain, but we had no cough, we had no night sweats, and there was no history of TB contact. So that's why we thought this could be less likely. So we went ahead and did the investigations, and starting with the CBC, when you look at the HB level, it was slightly reduced at 9.1 grams per deciliter. You can cross-check that with the reference ranges. The other things on the CBC were normal, as you can see. When you look at the electrolytes, child had a hyponatremia of 128 millimoles per liter, and we could attribute it to the vomiting that had been occurring for the last 3 days. And then he also had a hypochloremia of 93.4 millimoles per liter, which we could also attribute to the vomiting which had been happening for the past 3 days. As per the RFTs, we had a urea, which was reduced at 2.2 millimoles per liter. And urea can be used as a negative acute phase reactant, so we would understand if it was reduced. Creatinine was normal. The LFTs were all within range, so I did not include them here. Our MRDT was negative for malaria. A stool gene expert was also done because we were thinking of TB, and the result was that we didn't have any MTB detected. At this point, the blood culture and sensitivity results were not yet available, so they were pending. We also had a chest X-ray done, so this will contribute to our third poll question. So the question reads, what is the interpretation of this radiograph? Please feel free to participate. Among the options, we have increased cardiac silhouette, widespread with curly B lines, normal lung fields with mild scoliosis changes, localized lobar consolidation, consistent with bacterial pneumonia, and then hyperinflated lungs with flattened diaphragm suggestive of bronchiolitis, stroke, asthma exacerbation. Please feel free to air your thoughts and participate in the poll. Thank you very much.
Yes, let's feel free to interact with our poll question about the interpretation of the radiograph. We are short of time, so we are going to only give this about 10 seconds, and then we shall close our poll question. All right, Adrian, back to you.
Okay, thank you very much. Next, we also had an ECG done, and the features that stand out on the ECG really for this particular patient was that, first of all, we had a tachycardia. with a heart rate of about 116 beats per minute. And then we also had enlarged P waves. Normal range is about 80 to 120, but in this case, it was slightly enlarged at 124 milliseconds. And then when you look at the chest leads V1, V2, V3, and V4, particularly for leads V3 and V4, we have those high voltage QRS complexes that kind of show us that we have an enlarged left ventricle. And then we also had a cardiac echo that was done. And the conclusion on this cardiac echo was that we had features of rheumatic heart disease with perforation of the anterior mitral valve leaflet, severe mitral regurgitation, and mild aortic insufficiency. There was also mitral valve vegetations, which were indicative of infective endocarditis. So for the hospital course, on day one, the patient was admitted at the ED for 1 day, and we saw the patient drastically improve on the heart failure regimen with near normalization of respiratory parameters. The appetite improved, the vomiting ceased, the fevers resolved, and the patient regained some energy. He still had mild chest pain. There was also some tachypnea, tachycardia, and basal crackles. He was then sent to the cardiorespiratory ward, where he spent about 10 days. And on day 4, the chest pain had resolved. The child was no longer tachypnic. He had a respiratory rate of about 18 breaths per minute. The heart rate had also gone down at about 88 beats per minute. The chest was clear. There were no new complaints at that point. And the treatment, we maintained the same treatment as above. And for the chest pain, which had not yet resolved at this time, they had added oral diclofenac, and they did other repeat investigations, and these were all in range. I forgot to mention that sodium chloride had been added on, oral sodium chloride, to manage the hyponatremia, which we found. But at this time, the results for the repeat investigations came out, and the sodium levels were okay, so they stopped this sodium chloride. On day 11, which was the day of discharge, the patient really had no new complaints and was in fair general condition. And by this time, the results for the blood culture had returned on the 7th day of admission, but unfortunately, to my surprise, did not yield any organisms after 7 days of growth. The child was discharged on oral penicillin V twice daily, as well as heart failure medications, as earlier given, and was scheduled for review after 1 week in the cardiac clinic. The caretakers were cautioned on salt and fluid restriction, and then they were also encouraged to adhere to the medication. So at this point, I would like to again invite our expert, Dr. Andrew Chimera, to give us his pearls and pitfalls. Thank you very much.
Wow, very interesting. I think we can all see how we've navigated right from before to in the ED and taking a secondary survey and the changes, but you always maintain and you keep going back and forth with your where your patient is stable and you're taking your history to understand and appreciate, not bias your mind in one range. So you see a patient who has had a very interesting history of you have the blood transfusions and they come in later, 2 weeks later, a few days later, and now we're having a whole diagnosis of rheumatic heart disease. So you ask yourself the question, why the 2 blood transfusions? And I hope as clinicians, we're still asking us that we need to be quite exhaustive and thorough, but organized in our thought process. We knew right from the beginning, this is a child who has chest pain. So what are the possible causes of non-traumatic chest pain in this child? It could be something respiratory, it could be something cardiac. Then everything led us down to coming to rheumatic heart disease. So for me, the pitfalls here, one is the history, okay? The history that the parents gave seems to leave out a few important details. For example, did they actually have prior fever events? Did they actually recall if the child had, you say they did not have an immediate recall, but any fever could have been and missed out, and yet it was throat infection. Did they previously do any investigations that could have added value to our diagnosis? So history is very key. So if we have any missing links, then the medications that were given, some of them can also be problematic and cause this chest pain. Okay. In this case, you're already seeing that, okay, the chest pain is likely we had a cardiomyopathy, rheumatic heart disease, a bit of arrhythmias. That tachycardia can also cause a bit of ischemic pain. The hypoxia itself could cause the chest pain. So they are clear causes, but there are still also question marks in there, and they can be answered from clear history, family history of sickle cell disease, and the likes. Okay, the anemia caused by, let's say we have an infective endocarditis, could it actually cause us to require 2 blood transfusions? Is a question mark. Okay, so was there anything hematological that we could explore further from the history that was not given to us? Then also on the physical exam, okay, in the secondary survey, just looking out for any stigmata of chronic disease. So for me, that was something we needed to address. For example, I would expect that you're going to tell me, okay, there's no bossing, there's no, such things. Sometimes you may not even have them. Okay, but looking out for them and being thorough that you're not leaving anything out. Even in that history, we might not have had a sore throat, but did they have any other viral indicators of viral infections? Because remember, even these viral infections sometimes eventually can lead you to having these dilated cardiomyopathies. Luckily, yes, we have our echo shows more features of rheumatic heart disease and all, but in the history as we explore, don't narrow yourself as you get there. But for the apps in this presentation today, for me, I feel the team remained focused and tried to continuously, consistently explore the two systems, okay, and not narrowing their diagnosis to just one area, which can end up we could end up overlooking quite a number of things, even the malaria, like the doc was saying. Then the other thing at discharge, I saw for this child, they discharged them after 10 days. It would be good to treat at least for 2 weeks, for IE, okay, with continuous parenteral treatment, just to be sure that we cleared it and be sure we are not leaving out anything. I still think this is a child that we might need to explore a few other things, details from the history, try to appreciate why that drop in HB, why the anemia to that extent. And then where available, there are certain other things that can help you to appreciate. Could we be in heart failure? You do a BNP, the cardiac markers, the troponin itself. Sometimes if you're having an acute coronary syndrome or something, you can have an acute elevation in those. There could be other things, but that can be an indicator. And also when someone presents with chest pain, there are a number of causes. So we shouldn't narrow ourselves. So for me, it's really that the right things for me that we kept knowing which systems we are dealing with and trying to explore completely what are the possible causes. The other thing that for me was I would say was a pitfall are the gaps. For example, the blood transfusion, I still feel like that's hanging somewhere and we need to pick it up and explore it and just understand it. Could we need to do a peripheral film? Could we do, anyway, now there are done a transfusion. So that becomes a bit of a marred picture. But yes, and always having a multidisciplinary approach to the patient for me is something I would commend the team and how we manage this patient, because you can see already they were thinking, cardiologists were thinking, could we be overloaded? They're thinking, could we have a pneumonia, and maybe a pulmonologist, things like that. So yeah, I guess that's it from me. Thank you.
Wow, amazing, Dr. Chimera. Well, very insightful there that you've given us your feedback on this. And just to the audience, thank you in for sticking out this long, even after we are past our time. But you can see the amount of information that our expert is giving us here. That's part of our pearls and pitfalls in this case. Thank you so much, Dr. Chimera. We are going to just complete the remaining segment of our presentation with Adrian just giving us just a take-home message in the shortest time possible, in less than a minute, such that we also get some parting remarks from him as well. And as we're doing that, we have a post-test that is going to pop up. Use the post-test to just give us what you have learned from, in this case, the session that we have had today. Just fill in the post-test as well as we conclude today's session. Thank you so much. Adrian, over to you.
Thank you very much. At this point, I would like to kind of delineate some of the highlights and learning points. I want to center my brief discussion around heart failure. So we shall start by having a definition. So heart failure is a clinical syndrome where the heart is unable to maintain an adequate cardiac output or does so at the expense of an elevated filling pressure. So it's very important for us to recognize the classic presentation of acute heart failure exacerbation and try to delineate features of compensated versus decompensated heart failure to kind of give us a sense of urgency to address to the particular case and the associated sequelae. So some of the signs in the compensated phase may include tachycardia, but other mechanisms of compensation where you have activation of the renin-angiotensin and aldosterone system, and then you have the system of the natriuretic peptides. And then in the decompensated stage, you can have cold extremities, you can have an increased capillary fill time, you can have weak 3D pulses, you can have oliguria and an altered mental state. And a late presentation is hypotension. So it's not good to rely on that as an indicator. But you can see in our patient, we had cold extremities, we had an increased capillary fill time, and we had weak 3D pulses. So it kind of gave us an indicator that the patient was actually in a decompensated phase. So it's very important for us to intervene early with intravenous loop diuretics and be very cautious with the fluids. If we are to give fluids, really, we should be very cautious and kind of measure them with the output of the patient to kind of make sure that we do not have a situation where we are continuously trying to overload the patient, yet they're already struggling. But at this point, the intravenous loop diuretics would be good to help us achieve euvolemia and then start the patient on a heart failure regimen like we did, as earlier described, according to the guideline-directed management therapy, to kind of help them get out of that acute decompensated stage and gain control of their cardiac function. And to, as I earlier mentioned, to avoid fluid boluses, as these tend to worsen the clinical picture. At this point, I think those are enough learning points for us. The particular things related to rheumatic heart disease have been properly brought out by our expert, and I don't think I have anything to add. I just want to thank all of you for your audience for listening in for today's presentation, and to wish you a very nice evening. Thank you very much.
Thank you so much, Adrian Achiveru. Thank you so much to the audience as well for taking your time and allowing us your time to go on this long with the presentation. But as you can see, this is what we exactly had prepared for you. We didn't want to rush the case because we wanted everyone to go home with a take-home message. And our expert has brilliantly shown us how to go about the patient that presents into the emergency department and later on starts deteriorating in this case. It was brilliant to just see his thought process, and I hope that we have all learned some of the take-home messages in this case. From the rest of the team here at CPC, the Secretariat, we want to thank you all because we have completed our first year with the case-based series, and we shall be reinventing the CPC for next year, such that we have better sessions, better timings, and such that we have more involvement and bringing to you more emergency cases that we can both share and discuss. If you have that interesting case that you'd want us to come in and dissect here with different experts as well, please feel free to reach out to us at our email. That's at seed@globalhealthtrainings.com. And feel free to inbox any of us at the Secretariat here, such that we are able to reach out to you and include your case discussions in our series. Thank you so much for joining us and for taking time to be part of the sessions. We wish you Merry festivities and Merry Christmas, Happy New Year, until next year when we meet again with the CPC case-based series. Thank you so much to our experts for well preparation and delivering of this session. Remain yours truly, Okome Emmanuel David. Thank you so much for joining us.